Ankle sprains are very common. The majority are lateral ankle ligaments. Incidence of isolated deltoid ligament injuries is about 3 to 4%. Recent studies have shown that medial ligament complex is injured more frequently than expected. So occurrence in acute and chronic presentation should be considered. Deltoid in Greek means deltoides. It is triangular in shape. It is also referred as medial collateral ligament of the tibio-talar joint. Deltoid ligament is a strong triangular shaped ligament. It has superficial and deep components. There are 4 superficial bands: tibiospring, tibionavicular, superficial posterior tibio-talar, tibiocalcaneal ligaments, and 2 deep bands: deep posterior tibio-talar, deep anterior tibio-talar ligaments. The function is a medial ankle joint stabilizer. Superficial component is shown to limit mainly external rotation and resist the valgus stress of the ankle and hind foot. The deep component resists mainly the ankle eversion and lateral migration of talus. Mode of injury is while running downstairs, loading on uneven surfaces, while dancing with the body simultaneously rotating in the opposite direction. In acute mechanism, pronation or eversion trauma, force external rotation and abduction of the ankle. In chronic mechanisms of deltoid injury, posterior tibial tendon dysfunction may cause deltoid ligament as well as the spring ligament to stretch and lose its competence. This causes the medial longitudinal arch, puts pressure on the medial longitudinal arch and leads to valgus tilting of the heel and eventually a flat foot deformity. General classification of ligament injuries is type 1 partial tears of a ligament, type 2 is incomplete tear, type 3 is complete tear with loss of integrity of the ligament. Intermittent medial ankle instability classification is based on the location and severity of injury. Type 1 lesions are classified as proximal tears or avulsions of the tibionavicular or tibiospring ligament. Type 2 lesions are intermediate tears. Type 3 involve the distal tear of the tibionavicular and spring ligaments. History, we look for traumatic episodes, previous ankle sprains. In acute injured patient, it is severely painful, swollen on the medial side. They have inability to bear weight. In chronic cases, it presents as a medial giving way, especially when walking on uneven ground. Sometimes the pain may emanate laterally from subfibular impingement due to hand-foot valgus. On inspection, we look for any swelling, hematomas, malalignment, deformity, scars. Also for asymmetrical planovalgus and abduction of the affected ankle and foot. You palpate for the tenderness in the middle gutter or the deltoid ligament and the spring ligament. Also look for tenderness on the posterior tibial tendon. Clinically, you see for the integrity of the superficial deltoid ligament, which can be evaluated on a relaxed sitting patient with a hanging legs using the external rotation test, and a deep ligament can be assessed by the eversion stress test. The anterior driver test is also a valuable tool for diagnosing the anteromedial subluxation in a deltoid ligament insufficiency. To exclude the posterior tibial insufficiency, a single heel rise test is used. In a setting of a healthy posterior tibial tendon, the hind foot reduces into varus on a single heel rise from excessive valgus position. Imaging, we do ankle AP, lateral and mortise views, weight bearing if possible. We see for medial ankle clear space opening, deltoid avulsion fragments, syndesmotic lesions, any associated ankle fractures. Gravity view can be done. Stress radiography, we do a manual valgus or external rotation stress view. It is best performed under anesthesia. There we see a valgus tilt occurring without talar shifting during stress testing confirms an isolated or complete deltoid ligament disruption. 4 to 5 millimeter medial clear space is indicative of ligament disruption. Imaging MRI to see the extent of the injury and associated pathological conditions. Ultrasonography is used for acute ligamentous injuries, as well as to do a dynamic ultrasound study, which we assess the ankle stability and bony impingement. Diagnostic arthroscopy can be done. It detects the deltoid ligament insufficiency and anatomical structural abnormalities of the unstable ankle. We can also visualize the cartilage status. Treatment options for acute deltoid ligament injury. Conservative treatment. Majority of deltoid injuries can be treated conservatively without including without surgery. All grades of ankle sprain should aim for pain control. Protection, rest, ice, compression, elevation is encouraged in initial phase. Ankle orthosis can be given. In severe sprains, grade 2 and grade 3, we give rigid ankle braces, pneumatic walkers, fiberglass plasters. The main aim is to avoid eversion. Physiotherapy programs aims to optimize the range of motion, neuromuscular training. Physiotherapy helps in recurrence risk, long-term complications such as chronic rotational ankle instability, OAs, and capsular scarring of the ankle joint. In operative treatment, the middle third tears are treated with interrupted suture repair. Proximal avulsions were treated with suture anchor fixation, and distal avulsions treated by placement of suture anchors in the talus, threaded through the drill holes in the middle malleolus. The ankle is held in slightly inverted position while the sutures are tightened and secured. The remaining sutures from the ankles are used to imbricate the overlying tissues and reinforce the repair. Syndesmotic injury is associated with the acute deltoid ligament injury. Non-operative treatment is indicated in significant hindfoot valgus combined with stable syndesmotic injury. Treatment consists of a below knee cast for 4 to 6 weeks, followed by physiotherapy. Operative treatment is indicated in asymmetric hindfoot valgus and inability to bear weight due to lesions of the anterior inferior tibiofibular ligament and intraosseous syndesmotic ligament, grade 2 and grade 3. Diagnostic ankle arthroscopy can be done to assess the extent of the deltoid ligament and the syndesmotic injury. At the same sitting, surgical syndesmotic stabilization and deltoid ligament repair can be done. Ankle fractures associated with acute deltoid ligament injury. Non-operative treatment is done in undisplaced ankle fractures such as Weber A fractures combined with deltoid ligament injury. Operative treatment is indicated in Weber B and Weber C fractures. You can start with ankle arthroscopy to evaluate the joint, or intraoperatively fluoroscopy can be done to assess the deltoid ligament injury. After surgical fixation of the fracture, the medial deltoid ligament of the ankle should be repaired. In a lateral unimalleolar fractures, where the medial clear space is more than 3 millimeters, will also require the deltoid repair. Deltoid reconstruction in acute injury is very rare. If it is required, a free graft of plantar tendon with posterior tendon introduced to the middle side of the talus is done. Chronic deltoid ligament injury, non-surgical treatment, conservatively managed for 3 to 6 months. Physiotherapy, then insoles, braces can be given. Stabilizing shoes can also be given. Indications for chronic deltoid ligament injuries, operative indications are patient become asymptomatic with conservative, patients are symptomatic even after conservative treatment. The aims of the surgery is re-establish joint stability, correction deformities, reduce the risk of fracture.
Time up, sir.
Yes. 3 more slides. So main primary option is to tension the deltoid and from distal to proximal. Soft tissues are inadequate or stable. For a stable direct repair, augmentation can be done by tendon grafts or internal brace. So in summary, acute deltoid ligament injuries, initial treatment of isolated deltoid complex is non-operative and often successful. Deltoid ligament repair is indicated in failed non-operative treatment. Adequate reduction of an ankle fracture does not assure restoration and competence of deltoid ligament. Significant improvement was seen in clinical measures after deltoid ligament repair and stabilization of the ankle fractures or a syndesmotic injury. In chronic deltoid ligament injuries, failure to become asymptomatic with conservative measures, persistent of clinical instability, increased deformities, and limitation of professional sports activities are indication of a surgical intervention. In soft tissues are inadequate for a stable repair, reconstruction options are appropriate, augmented with or without internal brace. Thank you.